Okay, hello everyone. Good morning, good evening, wherever you are in the world. Welcome to this early morning session of AIS, which is titled Vitreo Retinal Surgery World Championship. I am Dr. Narayan. Along with me, we have our esteemed moderators Vivek Dave and Saravanan. We have an expert panel today of Dr. Avinash Patange, Pramod Bende, Dhananjay Shukla, Naresh Babu, Preetam Samant, Mahesh Shanmugam, Sangeet Mittal, and Gopal Pillai. We have two guest speakers from the US today who have kindly agreed to spare the valuable time and share their expertise with us. The first speaker would be Dr. Christina Wang, who's the Associate Professor of Ophthalmology at the Baylor College of Medicine in Texas. And the second speaker would be Dr. Prithvi Mrityunjay, who's at the Stanford University. I would now invite Dr. Christina Wang to give her talk on subretinal gene therapy. Over to you, Christina.
Thank you so much, Dr. Raja, and thank you very much to all of you for having me. Good morning. I'm going to get things started here. Can you see my screen?
Yes, Christina.
Yeah, the screen's visible.
Perfect. Thank you so much again for the invitation. I'm going to be talking a little bit about subretinal gene therapy and sort of where we stand in 2021. It's a very exciting area. These are my disclosures, none of which are relevant to this talk. So as we all know, gene therapy is really a burgeoning space. We have come such a long way over the past 4 decades since gene therapy was first explored in the mammalian model in the late 1970s. And you can see I've clipped this from the FDA. The FDA is the regulatory agency in the United States. In January of 2020, there were 900 investigational new drug applications sitting on the desk of the FDA. That's how much interest there is in exploring gene therapy, not just in ophthalmology, but for many different types of diseases. And I bet you that number is even larger just a year later. There's many different types of gene therapy, and they really go back to what type of genetic disease you're trying to treat. So the most common type is the autosomal recessive loss of function inherited retinal diseases in ophthalmology. And we address those through gene augmentation, also known as gene replacement or gene supplementation. A great example of this is Viretogene Parvovec, which many of you have heard of. This is from Spark Therapeutics and used to treat RPE65 deficiency. The second genetic disease type is autosomal dominant gain of function inherited retinal diseases. These notoriously and historically have been more challenging to treat, but we are making progress in this area. This requires gene suppression or inactivation, which is much more challenging from a pharmaceutical and biochemical and genetic approach. But things like small interfering RNAs and antisense oligonucleotides may get us to that step. And you have also probably heard of gene editing with CRISPR-Cas9, an RNA-based type of technology that allows you to actually very specifically edit out parts of the genome. And that's being looked at for diseases like Leber's congenital amaurosis type 10 with the Editas and Allergan collaboration there. And finally, multifactorial diseases are now being treated with gene therapy, right? Things like macular degeneration, which doesn't have a single locus where a genetic mutation is found, but we can still use gene therapy by leveraging the eye as a biofactory that's able to produce its own protein substrate, such as RGX314 and ADVM022, which allows the eye to produce its own supply of anti-VEGF. And the way gene therapy works, just on a schematic and overview approach, is that you have this transgene, which carries a modified DNA sequence. And this is injected into the cell nucleus. And the way it enters into the cell is actually through a vector, which is either a viral or a non-viral vector. And then the vesicle breaks down inside of the cell, and the vector then injects that new transgene into the cell nucleus, allowing the cell to produce this new protein. And this protein can either be a native protein like RPE65, or it can be a non-native protein like anti-VEGF, as I was alluding to earlier. And we've become much more sophisticated in our designs and our delivery of gene therapy these days, such that any part of the schematic can really be tinkered with. We can adjust vectors and the capsids on the vectors. We can adjust the gene cassette itself with inverted terminal repeats and promoters. And we, of course, can really be sophisticated now in the transgene itself. There are different diseases, many different diseases in the ophthalmology space that are being looked at as targets for gene therapy. And you'll see the classic inherited retinal disease, these rare diseases that we've been looking at for quite some time now, like choroideremia, Leber congenital amaurosis, of course, But you'll also notice that this list now very excitingly includes common diseases as well, like diabetic retinopathy and macular degeneration. There are 3 routes of gene therapy administration. There's intravitreal, subretinal, and suprachoroidal. And when you look at the subretinal route, which is going to be our focus for the rest of this lecture today, there's really 2 approaches to that. You can go through a transvitreal approach, as you see in the top left, or there's this new way that can bypass the vitrectomy itself called a suprachoroidal approach to subretinal gene therapy. And that's what you see down below in those last row of pictures there. That's the orbit system where you insert a catheter into the suprachoroidal space. And then once you get to the desired location, a small needle emerges and pierces into the subretinal space, depositing the subretinal gene therapy. There's no consensus on optimal approach, which is why all of these different delivery approaches are being studied. Now, there's a lot of subretinal gene therapy drugs. Can't cover them all in 8 minutes, of course, but I think if you were to leave my lecture knowing 3, these are the 3 candidates to know. The first is Viretagine Parvovec. It's really not a candidate anymore because this has become the first FDA-approved and only FDA-approved gene therapy in the United States in the ophthalmic realm. This is an AAV2-based therapy for patients with biallelic RPE65 mutation, which clinically manifests as Leber congenital amaurosis type 2 or rare types of retinitis pigmentosa. There's also RGX-314 from REGENXBIO. This is an AAV8-based therapy that encodes a monoclonal antibody fragment similar to ranibizumab and is being studied for wet AMD as well as diabetic retinopathy. It's very exciting because the first of 2 pivotal trials called Atmosphere is already started and enrolling. And REGENXBIO is also looking at the suprachoroidal delivery route as well. And finally, GT005 from Gyroscope Therapeutics is important to know. This is an AAV2-based therapy a little bit earlier on in study, but essentially what this does is it increases complement factor I in the body, which is a natural downregulator of the alternative complement pathway. And that's a good thing. You want more complement factor I in these cases of pathologic states. This is earlier, like I said, in study. It's been looked at in a phase 1-2 focus trial that is still ongoing. But so far, there are some positive efficacy signals. So exciting to learn, as well as from the phase 2 Explore and Horizon trials, which are ongoing. So what about the setup for doing this type of surgery? Well, mostly it's just a standard vitrectomy setup, but with a couple of additional supplies, as you can see here. You'll need a 41 gauge cannula. That's the most common way of getting these gene therapies into the subretinal space. That's usually connected with some polyvinyl chloride extension tubing. And then the gene therapy, at least for Viretagine, comes in a 1 cc syringe. And then the way you inject it, you can either manually have an assistant inject it for you while you're at that, while you're at the scope in the eye, or you can even do it independently by connecting this with the VFC system and using a foot pedal to self-control and inject that gene therapy into it. So I want to show you a couple of videos now. This is first a 6-year-old boy with RPE65 deficiency I'm performing subretinal Viretagine for. So core vitrectomy, elevating the hyaloid. I like using intravitreal triamcinolone here because they're usually young. I remove the valve from the cannula to prevent kinking of the 41 gauge subretinal cannula, which is very delicate. You'll see me sort of touch down on the retina. You look for blanching, and then you start injecting the 0.3 cc's of gene therapy. And you can see that bleb raise nicely. 0.3 cc's is how much we're injecting. I like to slow the injection velocity down a little bit as we're crossing the fovea, and the entry site will generally self-seal by the end of the case. So you don't need to laser it or anything like that. And then we perform an air fluid exchange. This is another case of a slightly older patient with RPE65 deficiency. She's a 30-some-year-old patient, but I like this case because it shows a nice application of intraoperative OCT, which is a nice adjunctive tool in these cases. When you're dealing with atrophic retinas, which are common in these inherited retinal dystrophy patients, it's very easy to actually go into the sub-RPE space, which is not desirable. And so intraoperative OCT can really help you confirm that you are in the correct location. And so you'll see me again raising that bleb 0.3 Cs of the gene material and then performing an air fluid exchange. I also like to suture all my sclerotomies in these cases to prevent egress of the gene therapy product. And again, that bleb, as large as it looks, will be resorbed by the next day. And finally, in summary, subretinal gene therapy has the potential to transform the treatment of both rare and common diseases. Viretogene Aparvovec is the only FDA-approved ophthalmic gene therapy currently available, but there's many promising candidates in the pipeline. There's lots of questions that remain, though, lots of learning to do because this is relatively a new area. What's the optimal delivery approach? What about these pigmentary changes that are starting to be reported in association with some subretinal gene therapy candidates? What are the consequences of constitutively active transgene end products? And what, of course, is the long-term durability? Is this really a one and done treatment? So lots to learn in the coming years. And I'm happy to take questions. Thank you again for the opportunity to be here today.
Thank you very much, Dr. Weng. I think that was really an illuminating talk, giving us a good overview of what are the types of gene therapies that are in vogue and sort of giving us an idea of what we can look at right up in the pipeline. A couple of questions that I had from my side. We saw the video where the patient was having the RP65 defect. What happens in cases, because many of these diseases are multifactorial or they involve multiple genes. So when you have that sort of a presentation, do we have an option for them? Because most of the therapies seem to be related to a single gene.
Yeah, it's a great question. And, the approach that I take, that phenotype is super common for a lot of different mutations. By looking at a patient like that in clinic, you don't necessarily know that they have a biallelic RPE65 deficiency. That is a requirement, obviously, if you're going to be treating them with viretogene. And so genetic confirmation with testing is very, very critical in those cases to first identify those patients. And, it's interesting. The second question that you ask really is, what about these monogenetic approaches? And that is tricky because if you take the most common inherited retinal disease, which is retinitis pigmentosa, there's over 100 genetic mutations that we've identified. And it would really take forever to really go through a research program for each one of those mutations. And so we're really looking beyond gene therapy as well to technologies like optogenetics, things that can bypass the specific mutation itself, but potentially still restore visual acuity or visual function to these patients.
Can I ask one question, Vivek, to Christina?
Yeah, please go on, Dr. Narayan.
Yeah, wonderful, Christina. Thanks
Thank
for
you.
the presentation. So I had a question on the pricing of Luxturna. How is it reimbursed? Are there any criteria for patients to be selected? And who can do these surgeries? Is any vitreoretinal surgeon allowed to do, or there are some centers where they have to be done?
Yeah, great questions, Dr. Raja. So Viretogene Aparvovec took an interesting approach, and I think they really set interesting precedents, being the first FDA-approved gene therapy that a lot of subsequent companies in therapeutics may follow in the future. They chose 10 centers of excellence. Baylor is one of them, which is why I'm able to give Viretogene in my practice. But there's 10 centers of excellence in the United States that where the surgeons have gone through specific training to be able to do this. And in terms of the pricing, it is very expensive. As you know, the R&D for these gene therapies is pretty immense. Each eye costs $425,000 US, which is probably the most expensive medication that we use in ophthalmology. But thankfully, they have a really good program that's set up. So first of all, the hospitals and physicians don't incur any of that cost. The cost is directly paid from the payer itself. And that's an arrangement that obviously takes a lot of groundwork before the patient is even approved. Now, in terms of approving the patient, you have to prove a biallelic RPE65 mutation through genetic testing, but you also have to, based on the retina specialist judgment, you have to be able to say that you think there are viable cells. And that's obviously a very hazy interpretation, but we do that with a combination of looking at the OCT, the overall vision, et cetera, and you try to make a judgment call. Right now, the reimbursement is not dependent in most cases based on their outcome, but that's been something that's been talked about, especially for future gene therapies. People have thought about perhaps linking the reimbursement of these very expensive medications to the patient's outcome. And, that gets tricky, obviously, for many reasons. I'll save that conversation for another day, but I hope that answers those questions.
Thank you, Dr. Christina. I think in the interest of time, we'll move on to the next speaker. I'd like to invite Dr. Prithvi Mithunsanjaya from Bayers to give his talk on surgery intraocular tumors.
Thank you very much. I hope you can see my slides.
Yes, Prithvi.
We're good. Great. Thank you to the committee and my good friend Raja for this invitation, and to everyone wishing your families good health and safety in these trying times. These are my disclosures. And I was asked to discuss whether we as retinal surgeons should be doing retinal surgery in eyes with tumors. So we have a very esteemed panel here today, but I convened my own panel to see if they could answer the question, and let's see what they said. It looks like the panel that I've chosen does not feel comfortable with retinal surgeons doing surgery in eye with tumors, but I think we'll see if there may be some exceptions to this. And as vitreoretinal surgeons, the main indications for surgery in these eyes are mainly for diagnosis and prognosis, treatment, either primary or secondary, managing complications, and in rare cases, for eye salvage. So we'll discuss these various considerations. When we look at diagnosis and prognosis, the most common intervention would be a choroidal biopsy. There's an increased use in uveal melanoma with genetic testing, with commercially available to determine prognosis, and an increased exposure to ocular oncology in many vitreoretinal fellowships. So we've been proponents of using 27-gauge vitrectomy instrumentation to do biopsies in patients with choroidal melanomas. I use a 3-port 27-gauge setup, which allows for good visualization with the inverter. We use the cutter to go straight into the tumor without doing a full core vitrectomy and engaging with high aspiration and low cut rate. And we basically take the sample, pull it out with the cutter. You may find a little bit of bleeding, but usually it's quite minimal. And when it comes out of the eye, we can expel the contents into a tube, and that can be sent for diagnosis as we need it, either for genetics or for use for diagnosis. Sometimes doing an intervention can be both diagnostic and therapeutic in its intention. This is a 66-year-old gentleman with blurry vision and a headache, had a previously normal CT scan, but was noted to have a retinal detachment and a choroidal mass. Of note, he has a 40-pound weight loss, is a diabetic, and has a history of hepatitis C, and is a former smoker. Here we can in the macula, as well as a rhegmatogenous detachment with an inferior hole, but we don't know where the primary tumor is in this case. So we did a combined diagnostic choroidal biopsy and a therapeutic repair of the retinal detachment. So we proceeded by placing an encircling scleral buckle and proceeded with 25-gauge vitrectomy, where we first identified the choroidal tumor and also the inferior retinal break. We did a peripheral vitrectomy in this case, which is because of the therapeutic intent. I aspirated some clear fluid and then a little bit of air up to the first connector, and we come up to the tumor site and come up to the edge of the tumor in an avascular location, put a little pressure on the retina and pop the cutter right through the tumor, reduce the cut rate, and obtain our biopsy specimen. We can come out, there's a little bit of minimal bleeding, which we can manage, and reflux automatically into the collection tube, and we can see multiple abundant small tumor fragments that we can use for assessment. And then it becomes the repair of the retinal detachment with endolaser. And as we flatten the retina, we notice that this patient actually had a second site of a multifocal biopsy metastatic lesion. The final diagnosis was metastatic esophageal carcinoma, and the retina remained attached on final follow-up. The second indication is to treat either primarily or secondarily the tumor itself. So we are aware that there's a lot of data on the use of vitreoretinal surgery in eyes with melanoma, either as primary treatment or to deal with secondary side effects. The treatment complications are usually what spur the retinal surgeon to treat these eyes, either vitreous hemorrhage, traction detachment, retinal detachment, but often it's uncommon, not often necessary, but it can be done safe and effectively. But I use it more in a conservative approach on these patients. Endoresection is a primary way to treat tumors that are required to be treated in eyes that maybe radiation may not be favorable, either tumors that are nasal to the optic nerve in an only eye, or those that may damage vision with treatment. It can also be used in the post-brachytherapy setting in eyes that have high levels of ischemia in terms of the, quote, toxic tumor syndrome. This is done with a vitrectomy probe to control the removal of the tumor tissue. Secondary retinal detachment will be induced, and that has to be repaired. Often these eyes require hypotensive anesthesia, and there may be adjuvant brachytherapy. As note, there are some complications, including the risk of venous air embolism during the vitrectomy that has led to some very sad cases of fatality. Here's a case of a large tumor nasal to the optic nerve, nearly 9 millimeters in thickness, first treated with plaque brachytherapy. And here, in a case shared by Dr. Zelia Correa, we can see the 23 gauge vitrectomy being performed, the large detachment at the site of the tumor. A biopsy is taken to obtain confirmatory cytopathology and genetic testing, and then the cutter goes in and you go to town. And the cutter eats away not only the retina overlying it, but also the tumor tissue itself. There's often abundant bleeding, which requires elevation of the bottle, and the hypotensive anesthesia can be helpful for it. Blood clots can be removed, and then finally the detachment is repaired. For the vitreoretinal surgeon, complication management becomes important as well. Here's a case of neovascular proliferation that's being managed with bimanual technique in a patient that's had a melanoma and subsequently developed proliferation and traction detachment. But retinal detachment itself is kind of the main indication for vitreoretinal intervention, and retinals detach in ocular tumors mainly for either tumor factors or for tumor-independent factors that may develop. And often these are combined mechanisms that come into play. Here's a 69-year-old patient with a peripapillary melanoma that was treated with brachytherapy. The visual acuity is quite good, and had adjuvant transpupillary thermotherapy as well. There's good tumor regression, but there appears to be persistent subretinal fluid and a demarcation line where we suspected that there was an atrophic break. So the patient underwent vitrectomy surgery. Here we can see the lifting of the hyaloid. We can see the placement of perfluorocarbon to stabilize the posterior pole, and dissection away with both forceps and bimanual technique with a lighted pick to clear the hyaloid into the periphery. Full peripheral shaving is performed and a candidate break is identified, and the retina is then repaired and endolaser placed around the tumor and the break. I always suture these sclerotomies, and I always place cryotherapy at the sites for protection. A patient here with retinoblastoma treated with intraarterial chemotherapy and intravitreal chemotherapy who had a persistent temporal retinal detachment. And retinal detachments are now seen in the post-chemotherapy area, even after external beam radiation, systemic chemotherapy, and up to 6% of eyes with intraarterial chemotherapy. In operating in eyes with retinoblastoma, it's important to know whether the disease is under control, what is the visual potential, and management of things like vitreous seeds, and also the concern about orbital seeding is always there. It is true that inadvertent vitrectomy has been performed on eyes with retinoblastoma. In this series from the LV Prasad Institute, Swati Kaliki shared 14 children who had inadvertent intraocular surgery, often thought for endophthalmitis and either vitrectomies or eviscerations, and presented with advanced retinoblastoma, including extraocular extension and orbital optic nerve extension. And in this, sadly to say, nearly 57% of these children ended up with progressive disease and passed away. So we talked about salvage finally, and a controversial technique that's being done in China is in eyes that are monocular with bilateral retinoblastoma, heavily pretreated, and in order to avoid enucleation, 3-port vitrectomies performed with melphalan infusion. With 3 years of follow-up, 18 of these eyes have been salvaged with no deaths reported, and 14 of these eyes have had functional vision. So we'll learn more about the long-term outcomes of this technique called tylectomy. So we've talked about the various indications for vitreoretinal surgical intervention. I'll leave you with my take-home points. Number one, avoid surgery in untreated retinoblastoma eyes. Confirm inactivity or non-malignancy of the tumor before you go in. Send the cassette for cytopathology just to be safe and sure. Suture all your ports and cryo to the surface of those ports, and confer with your ocular oncology colleagues and take a moment to pause. Not all of these eyes require surgery. Thank you very much for this opportunity.
Thank you, Dr.
Dr. Raja, can I just have a quick word?
Yeah.
Yeah. So, Partha here, and welcome to the last day, the fourth day, and the morning session. Thank you very much. Very, very special word of welcome to Dr. Christina and Dr. Prithvi from US. And thank you, sirs. Thank you, madam, for being with us today. I hope you have had a good experience, and I'm very sorry for all the technical glitches that have occurred. Thank you very much. Please carry on.
Thank you, sir. Just I would like to ask which Dr. Sandeep had put in the chat box as an open question to Dr. Prithvi. She was asking about the precautions to be taken to prevent venous embolism during resection, actually.
Yes, it's and briefly, I'll say that I don't think we know enough about that situation. We would try to avoid air infusion if possible, but I just learned of a case from the Moorfields Eye Institute of an eye that had an endoresection, no air infusion, only perfluorocarbon used to stabilize the retina, and the patient still developed what appears to be an air embolism. So I think we don't know exactly why and what is causing it. Obviously, high pressure air infusion where you have Barrett's sclera is a concern, but I think we'll be learning more as these cases are being combined across the world. So with caution.
Thank you, Dr. Prithvi. I think Dr. Vivek will now call the main speakers from the session.
Right. Thank you, Dr. Sarvanan. Thank you once again, Dr. Mrityunjay, for your illuminating talk. So we'll now go ahead with our case-specific video presentations. It would be a 2-minute video presentation followed by a 4-minute discussion in interest of time. I'll first call upon Dr. Srinivas Joshi to present his case on failed macular hole surgery. Dr. Joshi, please.
Thank you so much, Dr. Vivek, and I thank Dr. Raja sir also for inviting me in this talk and to be amongst the doyens in the vitreoretinal surgery. So I'll just start my screen share. Okay. So this was the case which I first started, and initially after any primary failed macular hole after the ILM peel, I go ahead and do what is called, as you can see there is no ILM. So I do what is called as the ILM transplant. So what I do here is I inject a little bit of viscoat in the macular hole, and then I try to peel a little bit of ILM from the temporal aspect and try to stuff it inside the mac hole. But I realized that the hole size was bigger and the flap was too smaller. So the importance here is to get a good single sheet at once. That is very, very important key. Otherwise, every time we have to keep stuffing it. And there is a danger that we might touch the RPE or the choroid. And here you can see I'm just stuffing it up intra-op OCT, and then you can see there is an excellent closure of the anatomical, and the surprise that the vision improved to 6/9 from 6/60. So this is my another case where I just thought I will do the same thing. This is I did about the macular detachment induction technique, which I'm going to describe, the pre and the post-op. We can see here. So I thought this would work. I had done 4 cases of that, but let us see what happened in this case. So here what I do is use a 42 gauge syringe and try to detach, do a macular detachment induction technique using a 42 gauge syringe, superior temporal and inferior to the fovea, and avoiding the papillomacular bundle. So what's the rationale of this? I followed this technique from one of my mentor, Dr. Curtis, and Dr. Rajiv Muni. He actually published in the Retina. Here, it reduces the tension and the stiffness, which is intrinsic to the retina, and separates the tight adhesion of the retina and the RPE. But we must ensure that the retina RPE adhesion is completely lysed around 360 degrees around the mac hole. You can see here, by doing a fluid air exchange, you can see the bullosity coming on, and we must ensure that there is a 360 degree complete lysis of the attachment. But unfortunately, you can see this. In fact, the hole size went bigger after this technique. And then I went ahead and did a neurosensory graft. Again, I injected a little bit of 42 gauge this thing. With the 42 gauge, I injected some saline and tried to create blisters because I don't want to inadvertently cut the RP or the choroid. And again, you can do it unimanually or bimanually, the various techniques where you can slide it under the PFCL also, whichever suits best in your hand. And then I just applied it over it, and we can see now it's placed over the MAC hole. I just did a laser to that. AIOC2021 confirms the exact placement of the hole, the flap, the retinal graft over the hole, and a careful fluid air exchange. And we can see here, there's a good improvement from counting fingers to post-op 6/36. Thank you very much.
Thank you very much, Dr. Joshi. I think that was a very deft sort of handling of the flap, which often gets lost when we are attempting to manipulate it. I would like to bring in Dr. Naresh Babu here. Dr. Babu, are you there?
Yeah, I'm there.
Yeah, good morning. So, Dr. Babu, in case one is handling such grafts, especially in high myopic eyes, where the tendency of the ILM to split off into smaller pieces keeps happening, how would you tackle the ILM graft in these situations?
Actually, one thing is you can fill the eye with the PFCL, and staining under the PFCL gives instantaneous staining. And because of the counter pressure given by the ILM, especially in thin retina like myopic eyes, it's easy to peel, number one. And number two, I think even you have published, there is not much difference in the visual acuity when you're transplanting the ILM in the macular holes. So I'm not really convinced about stuffing the ILM holes with macular hole, because there are two publications back to back which says there is not much of improvement. Maybe it can close the hole, but not the vision as such.
Right. So suppose one is attempting to do this maneuver, and when ends up having bleeding right there in the base of the hole, then would that be a matter of concern, or would we look at it as a positive factor, which may in fact help the hole to close?
Depends on which article you have read. If you have read Nina Chakrabarti's article, you will say it's, oh, I'm going to plug the macular hole with the blood. As she has told, in 3 layers, she has plugged the hole with the blood, and she has left it without tamponade also. So if you would have read that article, you are happy. Otherwise, you will evacuate and they will redo the procedure.
Right. Right. Thank you for that.
Dr. Vivek.
Yes, Dr. Joshi.
Question. Actually, I had one more case, the reproliferation of the diabetic retinopathy case, where ILM peel was done in the primary surgery. So while peeling the membrane, there was a slight bleeding. Even in spite of putting PFCL, the blood was coming over the macula. And at last, I lost the orientation, because the more the blood we try to pull in, the more enlargement of the macular hole will happen. Then I trusted, then I thought, okay, I thought it is the center of the macular hole, and I just left it. And fortunately, I don't know, the patient had a very good improvement. So I don't know whether to attribute it to the graft or to this thing, or double combo, both together helped him in getting a good anatomical as well as visual outcome.
But again, most of these cases are anecdotal, Dr. Srinivas, right? We'll have to have maybe a trial to say that whether they are really effective.
Yeah. We need a long set of cases to actually prove it.
Dr. Shukla, you would like to come in with a point? Your mic's muted, Dr. Shukla.
Shukla sir, you're muted.
Yeah, am I audible now?
Yeah. Yes, absolutely.
Yeah, there are two things. Srinivas, very good surgery, very skillful surgery, but I would say it's an overkill for two reasons. Actually, first of all, the macular hole you showed are not really large macular holes. The macular holes of 400 microns or more were considered large earlier, but now the Manchester study has shown, as my personal experience also, I'm sure a lot of other panelists also, up to 600 micron macular holes can be easily closed by a rexus which is done up to the arcades actually, and no special procedure required for that. So, doing a graft of a full thickness retina, even doing a flap, and one particular aversion I have is to insertion of the flap into the hole actually. If you layer the flap over the hole as a scaffold, that's an acceptable alternative. That's difficult to do. But if you try to stuff the matter as something into the hole, it actually prevents the photoreceptors from approximation. So that's my 2 points. Thank you.
Thank you. Thank you, Dr. Shukla. And I think in interest of time, we will move ahead. Thank you, Dr. Joshi, for that wonderful case. I'll now call upon Dr. Kshitij Kumar. He will be presenting his case on submacular hematoma. Please go ahead, Kshitij.
Is my slide visible?
Yeah, please carry on.
So,
Yes,
good morning to all. At the outset, I must thank Scientific Committee of AIS and Dr. Aryan for giving me this opportunity. So I'm here to present a case of subretinal cocktail mixture with subretinal pneumatic displacement of a whole submacular hemorrhage. So this is a case of a 67-year-old female patient who is a known pseudophakic, known hypertensive with a best corrected visual acuity of 1/60 with loss of vision. And we can see here that it was there was an old with fresh submacular hematoma. If I may go back to the slide. Yeah. So this is the patient had a vision of 1/60, and she during the lockdown she could not come, and probably it was of more than 3 weeks duration. And we can see a multiple level of subretinal bleed over here. We can see a subretinal bleed here, and then there's a blackish mound of sub-RP bleed with a dehemoglobinized blood, and we can see it very well on the ultra-wide field fundus imaging as well. And moving on to the OCT, so we can see that there's a tall rising PED with a double layer sign, probably PCV, and there's a whole subretinal heme in the neurosensory below the neurosensory retina. And again, the raster image confirms the multiple level of subretinal hemorrhage, and which was quite old in nature, and there was massive amounts of sub-RP hematoma as well. So with this, I move on. The plan was to do a 25 gauge fast planar vitrectomy with a subretinal cocktail injection of ranibizumab 0.1 cc with 0.14 cc of recombinant tissue plasminogen activator, so that the final concentration was not more than 50 micrograms along with air to achieve a subretinal pneumatic displacement. And the plan was to repeat intravitreal ranibizumab if submacular hemorrhage gets displaced. So with this, 4 vitrectomy was done, followed by tricot-assisted PVD induction and completion of vitrectomy. And this was followed by staining of the ILM, so that in case there's a blowout, and particularly if there's a foveal blowout, I would do a ILM peeling. And then the 41 gauge subretinal cannula was used. So the site of injection initially I chose was in the area of the dehemoglobinized blood. And as you can see that puffs of old subretinal heme started coming out. So I changed the site, and I could not appreciate that whether the blister was forming or not. So I changed the site to the superior area. And since the volume of the fluid was, which needs to be injected, the cocktail mixture was around 0.7 cc. So I had using it in a titrated and multiple aliquots was using. And at this point, the air escaped out instead of going in the subretinal space, though the blister had enlarged. So I came back again and tried to, now we can see that a fairly good amount of blister had formed. And so the final part was to achieve a subretinal air. So, but the air escaped outside as well as escaped towards the periphery, causing a localized detachment. And this probably happened because the sub-RP mound was so tight that it did not allow the air to collect below the macula, and hence the air followed the path of least resistance towards the periphery as well as regurgitated out. So I did not know what to do, so I just started with the fluid exchange, and thankfully the air retraced back towards the macula so that we could achieve a subretinal pneumatic displacement. And we can see that the air bubble has retraced back towards the hematoma. And this was a post of 10 days. We can, on ultra wide field fundus imaging, we can see that the hemorrhage had gone down, and a beautiful recovery of the macular anatomy was achieved. And this was 2 months post-op with a very good vision recovery. Thank you.
Thank you very much, Kshitij. Yeah, Dr. Saravanan, please.
Yeah. Just wanted to ask Mahesh sir, what do you think will be the efficacy of TPA in such large RP component blood clots? Sir?
RP usually doesn't seem to penetrate or have much of, because the RP space, sub-RP space is a tight compartment, the blood doesn't seem to move around. So that is the issue. So even if you inject in a subretinal space, even if it goes into the sub-RP space, that blood doesn't seem to move around too much. So it's probably continues to remain inoculated. It's usually the subretinal blood which moves.
You have this technique of injecting a air bubble in the subretinal space. Can you just elaborate on that technique?
Yeah, it's a previously described technique from Korea, if I remember right. It's the same thing. I think what Dr. Sitish had problems was, there are two things which I can imagine, which I think were the problems. One is the retinotomy size enlarged because of the movement of the 42 gauge cannula. But the second time, third time, that movement was not much. So I would think probably we went in too deep inside and it probably hit the RPE, or the tip of the cannula was blocked. So we were not able to inject, is what I would think is the issue. So this is a peculiar issue which seems to be the case in his case. What I would nowadays do is use another needle through which I thread the 42 gauge cannula, so the inadvertent movement is minimized. So a little larger bore, say if I'm using a 23 gauge, a 24 gauge needle is what I use through the cannula, so that the 42 gauge doesn't shift, doesn't move. The tremor is not noticed by doing that. That's another technique which I use nowadays.
Thank you, sir. Vivek, do you have any questions?
Yeah, I also wanted to ask Dr. Shanmugam, when faced with such cases, do you have any criteria which you use to decide whether would you use the tissue plasminogen activator? Basically, would you take up for such a big surgery, or you sort of would let go of these cases and leave them alone?
In this case, I would have probably injected intravitreal TPA and a gas alone rather than a surgery, because if you looked at the OCT, there was a very minimal elevation close to the fovea, and the blood was kind of bisecting the fovea, not lifting it. The subretinal hemorrhage was not exactly subfoveal. So in this situation, I would have probably injected gas and the prone position, so it may have shifted it below. But of course, Dr. Siti's surgery was wonderful, and he achieved the end result.
Dr. Naresh, if you're there, like you do a lot of submacular surgeries. Do you have any points to make in this regarding this video?
So in this case, definitely I'll not do submax surgery, because if you see, only half the fovea was covered with the blood, I think. So probably I think this would have been the best choice for this case.
Okay. How often do you use TPA in your practice?
Very rarely, Saravana. Not very often.
Okay.
Right.
If I can, other panelists as well. No. Okay, then I'd like to call the next speaker on the list, Dr. Manish Bapai. I think he's going to talk about management of odd irregular foreign bodies. No ball.
Good morning, everybody. I'll share my screen. Is my screen visible, sir?
Yes, Manish, you can carry on.
Yeah, thank you. So I'll be talking about odd irregular shaped foreign bodies. The first case, I'll just give a background since these are heavily edited videos in favor of time. The first case is a young patient who had a trauma while working in stone quarry and had a large stone foreign body. He had no perception of light, but still the foreign body needed to be removed. While the second case was a patient who had trauma, bike accident actually, and had broken glass, and there was a glass foreign body which was missed on ultrasound as well as on CT scan pre-operatively because of a very dense, thick vitreous hemorrhage which was there. And the patient was referred to us after primary wound repair was done elsewhere. So the first video, after the sclera was sutured on the nasal side, and the lensectomy was done, the vitrectomy was done, and foreign body was released of all the vitreous attachments, and then the sclerotomy on temporal side was opened. The claw forceps was used to lift the foreign body from the retinal surface and held in mid-vitreous cavity, while other hand was used to make a limbal incision, which is almost 180 degrees. And then the superior rectus forceps was used to remove the foreign body from the limbal incision. At the end of this was a very large foreign body, as can be seen. This patient eventually ended up with parathysis. He never regained perception of light and eventually ended up with thiasis bulbi. The second patient, here the vitrectomy was done, peripheral vitrectomy is done. We can see it was densely adherent. It was very dense vitreous hemorrhage, and it was organized because of old trauma. It was almost 3 weeks old. There was this glass foreign body. So again, the forceps was used to lift the foreign body from the retinal surface and was brought onto the iris. It was left on the iris, and the prongs of the claw forceps were retracted before taking it out of the sclerotomy. And then it was again inserted through the anterior chamber, and the foreign body was grasped while on the iris surface and then removed from the eye. This patient had fairly good visual outcome. I think he had 3/60 meters vision after the recovery of the eye. Thank you for opportunity, Dr. Raja and VRSI.
Thank you, Dr. Manish. It's a very nice demonstration of the usage of the claw forceps. I think I'd like to congratulate on you designing a very nice forceps, which is one of the big lacunae was there in managing non-magnetic foreign bodies of large size. So I'd like to ask, what is the maximum diameter of the opening of that lips of the claw?
Sir, it opens up to, so the prongs are made of nitinol. So without having to force them open it, they open up to 8.5 to 9 millimeters. But since the nitinol tends to, it can change its shape a little, you can grasp larger foreign bodies. So the stone foreign body that I removed was almost 11 millimeters. And as you can see, it was very odd and irregular shape. So despite that, the prongs did not, they were not damaged. We could reuse it.
Great. Do you have any other design forceps which designed for other purposes? Like, this is the only thing you have, or do you have any other designs which are pending or in the pipeline?
So as of now, nothing else in the pipeline, but I'm sure there are various different types of forceps which have been designed now. The basket types, type of forceps are also available, which can be used to remove such large foreign body. I think there is one designed in Arvind Eye Hospital itself, which can also be used for such foreign bodies.
I'd like to ask Dr. Preetham, how does he manage large non-magnetic foreign body? Does he have any other techniques which we could like tips to remove such very large non-magnetic foreign bodies?
Yeah. First of all, great management of these IOFBs with your claw forceps, Manish. When it comes to glass IOFBs, one thing which I found useful, these IOFBs usually have a smooth surface. So, I use my silicon tipped cannula connected to active extrusion. It seems to grasp the foreign body pretty well. So with that, you can get it into the mid-vitreous or anterior vitreous cavity and then handshake it directly from the limbus where you made your excision. You don't want to handshake it from the other end because it will fall down again. So you could handshake it with a forceps which has a serrated edge and then bring it out. So this is one thing which I have found useful.
If I may, you can use this technique with claw as well. And Dr. Sangeet Mittal has a lot of videos where he has used claw to remove even the non-magnetic foreign bodies, where since the diameter of the claw forceps is smaller than most of the magnets that are available, you can use this bimanual technique even with claw forceps to remove it. You can lift the foreign body from the retinal surface using your cutter in one hand and then use the claw to grasp the foreign body.
Thank you, Dr. Bape, for that wonderful presentation and some nice discussion coming out of it. We now go ahead and will ask the next speaker, that is Vinod Kumar. So Vinod will present on a post-trauma retinal detachment.
Thank you so much, Vivek. So is my screen visible and am I audible?
Yes, carry on.
Yes, Vinod.
So I'll be presenting this case of a 30-year-old male. He is in fact a student of our institute only. He's a high myope, -10 diopter OU. He had had a trauma and underwent corneal tear repair in his right eye. Though he retained a very good visual acuity of 6/6, a large corneal tear had been repaired by one of my seniors in institute only, and had traumatic aniridia as well. And the patient was aphakic. Now, this is what he presented with. He presented to us with decrease of vision in the same eye for past 1 day. The visual acuity was finger counting close to face, and he had a large superior 210-degree giant retinal tear. So this is what I did. It was in fact, not very difficult surgery because PVD was already present. So I continued with my vitrectomy. Once the vitrectomy was complete, I shaved off the remnant edges of the retina, which were there in the periphery. After that, the retina was rolled superiorly and PFCL bubble was injected into the retina. We noted that the patient had a myelinated nerve fiber also. Once the PFCL was filled up to the brim, a thorough laser 360-degree, 5 to 6 rows of laser were done. And now subsequent parts were challenging, but I decided to go ahead with the air fluid exchange in this patient. Air PFCL exchange, and once air PFCL exchange was complete, I could see there's small amount of subretinal fluid noted in this compartment, but I did nothing and left the patient with C3F8 gas tamponade. So this is what happened over a period of time. The retina remained attached. In fact, patient attained 6/6 to my surprise in this patient. Probably macula was not detached to begin with. And now it's been 2-year follow-up. The patient has been doing very well. So the challenging in such a patient were visibility, aphakia, aniridia, and the large GRT. The patient had 3 factors for a high-risk PVR, that is high myopia, post-trauma, and a large GRT. And what I wanted to discuss was how to go about direct PFCL siliconal exchange in such patient. Because there is no lens iris diaphragm, so there are chances of anterior chamber filling up with silicone oil. And what would be the choice of tamponade in such cases? Because there's no iris lens diaphragm again. I was able to get away with gas in this particular patient, but how to go about? Thank you very much.
Thank you, Vinod, for that wonderful presentation. I would like to bring in Dr. Pramod Bhende here. Dr. Bhende, in such cases, especially the ones which are aphakic, the way he showed right now, would you prefer gas or would you swerve towards usage of an oil?
Well, I think it's a wonderful video. Let me appreciate that surgery was done extremely well and very gentle handling, I would say. And he was lucky enough that macula was attached and superior GRT that helped out. Yes, I won't say it's a clear consciousness whether oil or gas. I think most of us feel this type of eye is dealing with particularly large tear, particularly high myopia, and as you rightly mentioned, post-trauma, there is a high risk of PVR. You generally tend more on, rather I would say, on oil side rather than gas. But I think it's a very common sense thinking because there's no iris, no lens, and probably chances of obviously oil cornea contact and already had an injury, corneal injury. He took a chance, unfortunately it worked out. That's what how I would feel. And whether to do oil PFCL exchange directly or PFCL air and then followed by silicone, I think it's a individual perception rather than the way you are trained with. Both are okay as long as technically and as long as you are good enough and confident enough, both way are okay. Okay, so probably we are all trained with directly PFCL and silicone oil exchange. I would do that. Probably I would say you cut off one step of having a air inside in between, and chances are there if you do properly that subretinal what he had a localized fluid, you can minimize that risk. But and another advantage is like reflexes what you get with air, and chances of PFCL sometime vaporization and bubble, residual bubble, you can miss when you are doing with the air. But you can debate on either side. I would say the way you are trained, the way you are comfortable with, either way is okay.
Dhananjay sir, can I ask you a question? Shukla sir? He's not there. Okay,
Saravanan?
Yeah.
Yeah, he's there.
Yeah. Can I make a point?
Yeah, please.
Actually, in all these cases, we just keep the PFCL for 10 days and remove the PFCL. No tamponade after that.
That's exactly the question I want to ask.
Yeah, so you just keep the patient supine for 10 days with PFCL, and at the end of 1 week or 10 days, initially we have been replacing with gas, but later on we thought, okay, we'll just leave with air alone. They're doing well actually, because the attachment of the retina with PFCL is very great actually after 10 days.
So Dr. Babu, is that your practice pattern in all cases of GRT, or is there a specific
Exactly,
All right.
exactly. So we have two groups where we are doing silicone oil and another group where we are doing only the PFCL.
It's good, sir, because Steve Jobs has also described it a midterm PFO of 2 weeks, and he has found great results. But the only thing is the inflammatory action which might occur with retaining this PFO for a long time. But it is doing well. But what about in LVP? I heard they're doing a double sandwich technique. What about it, Dr. Vivek? I heard somewhere.
I think Dr. Aryan, yeah, he's there. I think Dr. Aryan has done a few cases.
Yeah, I do sandwich with PFCL and silicone oil where there is extensive PVR. I need both superior and inferior tamponade. But recently also I had to do one patient where the retinectomy was up to the arcade actually. But overall, I would say I hadn't heard about the retaining the full PFCL inside and removing it later on. I don't know if the patient doesn't come for a few weeks. Is there any toxicity that you have seen? Even in my patients, there is always a risk when I do the PFCL oil sandwich. The other problem which I face with PFCL oil sandwich is they don't come on time, then the oil and PFCL can mix actually, making the PFCL viscous and difficult to remove. So I will have to try out these PFCL cases only.
Rather, we don't discharge the patient actually for the same danger. So we keep them in the hospital only for a week because I don't want to miss them and end up in any MLC.
Dr. Shukla, can you quickly come in? You want to make a point? Dr. Shukla, you're not audible.
Am I audible now?
Yes, you are.
So I'm sorry. So the thing is, Naresh actually stole my words. Yeah. So but the only catch is if there is an inferior GRT, I would be more happy using PFCL as a midterm tamponade. If there is superior GRT, I would probably go with Vinod or use oil actually. So that's the only difference I make. Vinod, actually, there is one more thing which Avneet does actually, making a plus with the with the threads actually to make a false pupil, and that prevents the oil from coming to AC. So that's the answer to a question about avoiding the contact of oil with the AC. The beauty of PFCL, Raja, is that the PFCL does not emulsify. It does not cause as much corneal toxicity as silicone oil. I've done about 40 cases and I'm very happy with my results actually. And as Naresh said, actually, it's actually a cleaner procedure. And in Ireland, actually, there is an entire group doing only PFCL now for GRTs. Thank you.
Gopal, I'd like to ask a question.
Yeah. Sorry?
Yeah, Gopal is there?
Yeah, I'm there.
How important do you think is trimming of the anterior edge of the GRT? Do you do it regularly in your practice?
Yeah, I do it regularly. Basically, the proliferation which is going to occur, the ischemia that it is going to cause later, the possibility of a neovascularization, peripheral neovascularization, anterior hyaline proliferation is there. So generally, I trim it. I have never left large areas of anterior tissue there.
How do you manage with the slippage? What do you think are the percentage of cases which you end up with slippage, and how do you manage if it slips?
Generally, I have been using oil in most of the patients. And one thing is, don't put buckle in those patients. Number two, I generally have the PFCL till up the brim, and I do a PFCL silicone oil exchange. And if it is very mild slippage, I do not actually do anything about it. Very mild slippage in the periphery, I would not actually mind it. But if it is more, then probably you may require to position the patient and only PFCL, just like Naresh was telling, we'll position the patient with PFCL and plan for a removal of PFCL in within 2 weeks' time.
Sangeet sir, you have any comments on this case or the follow-up chat which we had? Okay.
Can I make a quick small comment? Quick one. Yeah. You know, I have had the observation over the years that many times the posterior edge of the GRT is rolled up intrinsically. You know, and although you cauterize it, that rolling up causes these islands of pockets of SRF when you finally do the PFCL oil exchange. So, you know, I've observed that cauterizing those edges, you know, and probably chopping off those small rolled up edges and leaving a straight edge at the end helps, you know, for a better results.
Exactly. It's critical that you leave a flat edge at the end of surgery because the chance of recurrence would be much lesser. So I think we'll move on to the next talk. Vivek himself is presenting the talk on subfoveal abscess dugout.
Thank you, Dr. Sarvanan. I hope I am audible, visible, right?
Yes, sir. Yes.
Yeah, thank you. Thank you. So I'll start off with the case. This was a 35-year-old male. He was a case of having diabetes mellitus uncontrolled and a background chronic renal failure, and was undergoing regular dialysis. The right eye was lost to an old retinal detachment many years ago. And this is what he presented with in the left eye, vision of 20 by 400, near vision less than N36. And the history was since the last 10 days, slow gradual loss of vision noted. So in general, if we see the fundus was clear, there were a few sort of lesions over the posterior pole indicative of few cotton wool spots which were resolving. The area of interest right at the posterior pole, that is under the fovea, we saw that there was a hemorrhagic retinitis and the lesion was elevated. Rest of the vitreous cavity otherwise was clear. When we did an OCT through the lesion, again we see that the posterior vitreous cavity is not really showing any cellular reaction. It's largely quiet. The retina showed a little bit of edema, but below the retina, in between the photoreceptor layer and the retinal pigment epithelium, we see this reflective aggregation of a lesion which was sitting right below the fovea. So given the background of his systemic conditions, given the look and nature of the lesion, we suspected this to be infective. And this patient was taken up for a biopsy to establish the diagnosis. This is what the patient looked like. As we started off, in order to gather sample from right close to the lesion, I did a sort of a dry vitrectomy, collecting sample right from close to the lesion. And once the vitreous sample was collected and the rest of the vitrectomy was completed, we concentrated then on the macular lesion per se, and material was then aspirated using a 41 gauge needle from within the lesion. If you look at the bore of the needle carefully, you will slowly see whitish material rising up the bore. This was then collected, and immediately a part of it, yeah, here you can see it's rising along the bore, was immediately plated onto an agar plate, and the rest was also sent to microbiology for microbiologic evaluation. So we found nothing grew from the vitreous sample, but the subretinal aspirate grew Candida albicans in the laboratory. This patient was over the period of next couple of weeks given 3 repeat injections of intravitreal amphotericin B. This is what he ended up with 1 month down the line. The macular lesion had largely regressed, vision had come up to 20/80 and N18. And this is what his fovea looked like at the final visit. So thank you for the attention. I would like to ask the panel, especially I think I would put it to Avinash. Avinash, how would you deal with such cases? Do you also go for an aspirate, or do you treat empirically or pick up sample from the vitreous cavity?
No, thanks, Vivek. The excellent outcome of the case. And the diagnosis was straightforward in terms of endogenous endophthalmitis, which had in this patient. So then find out what could be the possible organism which would have caused endogenous endophthalmitis. Now, the key factor, there are a couple of factors in this to make a clinical diagnosis of what the organisms could be, because the history was 10 days, the vitreous was so clear, and the lesion was predominantly in the subretinal space and little bit of retinal hemorrhage which was there. So this is a condition which is commonly seen in Candida type of endophthalmitis. Now, if you look into endogenous, you have the filamentous fungi, Aspergillus, and then you have the Candida. These are the two most commonest cause of endogenous endophthalmitis in fungal organisms. But Aspergillus, in 2 or 3 days, it spreads, and it spreads not only horizontally, it spreads into the vitreous with a lot of inflammation. So in the absence of inflammation in the vitreous and predominantly localized in the submacular space, I would think Candida is the first in the differential diagnosis. So the answer to the second question, whether I would have done something differently, I would not have gone into the submacular space like what you would have done. I would have done the first part of it, going over the vitreous, going over the lesion and try to get, and then treat as per the empirical diagnosis what I have made on the clinical observations. Systemic antifungals is one indication. It's a exact subretinal location is one of the indications where you can still try a systemic antifungal and can get away as well.
So Avinash, given the OCT, what intrigued me or what made me go into the subretinal spaces, the OCT was pretty quiet right there in the posterior area. So that is where I felt the necessity to go inside the lesion per se. So you would still possibly take a vitreous biopsy in the first go, right?
Yeah,
right.
Subretinal intervention would be the second in my list to go for, not in the primary thing. So because Candida, most of the Candida responds very well, and we also have to understand the duration of the treatment for Candida. Unlike bacteria, it takes nearly about 4 to 6 weeks, and it is not one-time treatment.
Dr. Shanmugam, you want to come in with a point?
Yeah, I was wondering if you could have considered a therapeutic challenge of injecting an intravitreal antifungal. I would ask Avinash this: is it so toxic an intravitreal injection of voriconazole or amphotericin is going to cause damage to the eye? We could have tried an intravitreal, a therapeutic challenge of an antifungal. Beautifully done surgery, Dr. Vivek. Anyway.
Thank you. Your question was about the inflammation induced with
amphotericin. Could we have, instead of doing the surgery, could we have considered a therapeutic challenge? So just giving an empirically giving an intravitreal antifungal, one injection. Yeah. So, are we causing any harm to the eye?
No, I don't think so. We are causing any harm because though we inject amphotericin inside the eye, and when we are removing the vitreous from over the area where the actual site of infection is, I don't think so. Though amphotericin can cause inflammation, it is known to cause inflammation. That's one point. And we also have to understand that in an eye which has not undergone extensive vitrectomy, the half-life of amphotericin is nearly about 5 to 7 days. So, of 5 microgram which you inject. And the third point is voriconazole has an extremely short half-life, about just 6 hours. So, these 3 points we have to understand when we have to manage with intravitreal antifungals. But even systemic fluconazole is good enough for management of these cases. We don't have to go up to voriconazole. They respond well even to fluconazole. And needless to say, just one point to find out the possible systemic source.
Avinash, what is the reason for all these infections localizing in the subfoveal space rather than in the periphery or the mid-periphery? Is there any logic in that?
It depends on the size of the organisms surrounded, because these Candida are very small. They tend to localize in the subfoveal area than in the peripheral area where the vessels are larger, and because of the dense vasculature in the subfoveal area, the finer caliber of these vessels, they tend to localize more in the subfoveal area.
I had one question to Avinash sir. Sir, in case of intravitreal injection and vitrectomy, as you said, is voriconazole is 6 to 7 hours. Then how will you assess the treatment to the cause? Like how frequently you give the injection in these cases, or how would you observe that whether it is responding to that drug and then decide for the next schedule?
Now, one thing you have to see is, Srinivas, when you're looking at fungus, don't try to expect what is the type of response you're looking at to say that it is responding. So the size of the abscess should shrink, or the height on the OCT also you can see. Clinically, you can see well rounding of the margins, and on the abscess height will be decreased on the OCT. Those are the 2 parameters by which you can consider. Now when we have to repeat these antifungals, so if you just have to repeat antifungals, just like fluoroquinolones, oriconazole must have to be done every 24 to 48 hours if that is the primary modality of treatment which you consider for the as intravitreal as a monotherapy. But if you consider amphotericin, since we are injecting 5 microgram inside, what I do follow in my practice is after 3 days, I reduce it to 2.5 microgram and keep injecting to maintain that concentration in the eye.
What are the indications?
Extreme apologies, sir, but can I request you to please take this questions in the chat box so that we can move on to the next presenter, because we have 2 presentations more till 9:30.
Okay then. Okay then. So just wanted to ask the last question to Avinash, like what are the situations where you use injectables or oral oriconazole?
No, both we can use. So we have the primary modality, and then the systemic is always an adjuvant treatment which could be considered. But if we go back into the history and see the initial papers which came out from Harry Flynn, the subretinal location of the lesion, which does not transgress through the retina or into the vitreous, is one of these indications where we can get away even without an intravitreal injection and just try a primary systemic treatment in such kind of endogenous endophthalmitis.
Thanks, Avinash. Then I'd like to call the next speaker, Dr. Sudipta Das. She'll be giving a talk on nucleus drop diving catch.
Good morning, sir. Are my slides visible?
Yes, carry on, Sudipta.
Oh, thank you so much. Thank you, Dr. Raja, for this opportunity on Airways. I'll be speaking and be giving, just showing 2 videos of nucleus drop, because most of the time it's not planned. So I don't have any financial disclosures. So you know that the incidence of this complication is much less. In Indian studies also it's around 0.8%. And it's associated with significant rates of intraoperative or postoperative complications, which is very important to keep in mind. But with good achievements, with good surgery, the patients, 80% patients usually achieve a good vision of 20/40. So most of the time it happens during grooving, cracking, or emulsification, or very less conditions where we see in hydrodissection also. And timely detection of the rent is very important. And anterior segment management, definitely we should avoid fishing out these materials. This was a patient combined surgery, hard diabetic cataract, non-dilating pupil. So the anterior segment surgeon was being able to manage nicely. The visualization and the glow was very poor. You could see the last fragments going down. So these are the few things which we feel that most of the time the anterior segment surgeons have a problem. If you have a vitreous in AC, the management is definitely we have to inject OVD into the anterior chamber and then remove. There are 2 techniques being described by Dr. Kelman and Chang, the PAL, the posterior assisted levitation technique, and the visco trap technique. I would request our esteemed panel to comment on this, because risk of retinal attachment is around 10 to 26% in these cases. So when it comes to the posterior segment, we have this, sometimes have this dreaded complication of having a nucleus drop. So this patient, this was intraoperative when a 56-year-old had a drop nucleus. He was referred. Almost 3/4 of the nucleus was in the vitreous. After good vitrectomy with cutter, when we tried to remove the posterior vitreous also, it was nicely managed anterior segment. A 20-gauge MVR was introduced to accommodate the pragmatome, and the fragments were slowly pulled up by suction initially to the mid-vitreous cavity, followed by phaco energy to emulsify the lens. So all the fragments were gradually, the light pipe sometimes helps in removing or dividing the lens fragments, and the residual fragments a lot of times can come in by passive suction. It's very important to not to keep the fragmentum very close to the retina while removing the last fragments. So this patient was, after this nucleus removal, as he was having intact plexus, a 3-piece IOL was put into the sulcus, and patient actually recovered well after this surgery. So this was a 3-piece which was put. The second patient, this patient also had an intraoperative complication. It was induced, and you can see after during hydroresection, the nucleus has dropped, but we couldn't see the nucleus in the initial vitrectomy part. So the peripheral excision of vitreous is very important after removal all this cortical matter. If you can see that stuck at the mid pars plana inferiorly along with vitreous. So after gentle excision of the vitreous base with scleral depression, we could slowly free the nucleus from the retinal surface. And then once it is absolutely freely mobile, the patient actually was approached in a different technique. MVR, 23 gauge MVR was slightly impregnated on the lens surface. It was not very hard. And then it was
the first
and then it was removed by Vectis. Scleral fixating intraocular lens was done in the same sitting. Patient recovered well. So these are the few take-home messages for mostly for the anterior segment surgeons. The last point I would like to highlight: the 2/3 patients with dropped nucleus at the final visual acuity or 6/12 or better in studies. Thank you so much for your patient hearing.
Dr. Sudipta, I saw that you are not using PFCL in any of the cases. Like, what are the indications do you consider PFCL in such scenarios?
Sir, the second case, I would definitely prefer to have PFCL, but most of the time I prefer to give PFCL in patients where I feel very hard nucleus. I have not induced PVD, or maybe I'm not getting the PVD age completely. So maybe that time I usually put PFCL to remove some residual fragments and then induce the PVD again. But most of the time with good fragmentome, and maybe if you can gently pull up the nucleus matter, PFCL most of the time is not required in this scenario.
Dr. Preetham, if you're there, can you just give your tips on how you go about preventing bouncing of the hard nucleus when you're doing fragmentation in these cases?
So, if you look at the power, the phaco fragmentation power, I think that I usually keep it on the lower power, because what happens is when you keep it on a higher power, the vibration sometimes disengages the nucleus from the tip, the fragmentome tip. So I usually keep it on low power. I keep the suction little on the higher side. So that is one thing which you can do so as to keep the nucleus engaged in the fragmentome at all time.
Mahesh, if you're there, like how often do you use the MVR blade to pierce the nucleus and bring it up? You're using it earlier a lot of times, but I feel it will put a little bit of pressure damage to the retina, especially if it's situated in the posterior fold. Do you still use the MVR blades, or have you given up on that?
No, only if it is a brown nucleus, Dr. Saran. If it's a brown nucleus where the fragmentome may not cut like Preetham said, it's likely to bounce it off. So in that situation, I use it as a lollipop, keep it in the mid-vitreous and use the fragmentome. Fragmentome bouncing you can avoid by using the pulse mode, in which case the interval between the pulses keeps the nucleus at the tip of the fragmentome. So I use it very rarely, but I would use it as a lollipop. That's what I would do.
Thank you, sir.
I think I was trying to make in terms of the power which could be used in the fragmentome, because the earlier textbooks used to say 10 to 15%. There used to be a prescription of the usage of power of 10 to 15%, but it depends on about how dense the nuclear sclerosis is. So if we have to have 10 to 15% for NS4, then it will take ages for us to emulsify. And also the fragment, and if it's on the contrary, if you use a very high power for a very soft nucleus, that's the time when it can get all over the place. So use adequate power, and we have to titrate depending upon the machine and how old is the fragmentome which is there. And depending on density, on these three factors, we have to titrate the power for us on case-to-case basis.
And regarding that point, I think there's no need to keep using old fragmentomes. Like you have to keep changing the tips. It's not expensive, hardly 3,000, 4,000 rupees. So always make sure that you have a new, if you feel it's not functioning well, always feel free to change the fragment tip because it's not expensive at all. With that, I think we'll move on to the last talk by Dr. Atul Dhawan. He's going to talk about his technique of closing macula holes using a temporal ALM flap extra cover. Atul, your slides are visible. Voice is not there.
There is no voice, sir. I am just going to. Inverted ALM flap surgery is the most common type of surgery for the large macular hole these days. I am going to talk how to make temporal ALM flap surgery as easy as possible by CAP technique, that is chromovisco-assisted ALM flap placement technique for the large macular hole. So the two main problems in the large macular hole temporal ALM flap surgery is, first is to make a proper large single flap. The second one is to keep the flap over the hole till the end of the surgery. For the second, I have made a technique that is chromovisco-assisted ALM flap placement technique. Now, how to make this viscoelastic visible? The answer is to color it. This is HPMC 0.6 to 0.7 ml. Then color it with the brilliant blue, 1 or 2 drop. And the status of this colored viscoelastic in the eye, if you take a transparent viscoelastic, you will not be able to see intra-op. But if you color it with the help of the brilliant blue, then you can easily see it. You can easily take out it at the end of the surgery. So this is a 180-degree ILM flap, 550 micron. 3 years back I have done. I have started the surgery with the finish loop. You can increase or decrease the length of the finish loop. And I have started with a pinch and peel technique from one side to the other side. Always go towards the base of the ILM flap and make a large ILM flap, because it will keep the flap over the hole for a long time. Now support it with the colored viscoelastic. Later on, you can take it out. And you can see with a single flap, you can do the surgery easy. Thank you.
Thank you very much, Dr. Dhawan. I think that was a very wonderful technique demonstrated, very nice, clean video to help us understand how that method works. If I can bring in Dr. Christina Weng at this point. Dr. Weng, in your experience, how do you deal or use ILM flaps for such macular holes?
Well, I think, first of all, Dr. Dhawan, that was a beautiful video and really brilliant to stain that viscoelastic so you can actually see where it's going. And I look forward to trying that in the future. But, you know, I think the ILM flaps are a great technique. You've heard earlier already in the session that a lot of different techniques exist for macular hole repair, but this is one that I also use frequently. And, you know, I agree with you that the hardest part about it is getting that flap to stay where you want it, especially if you make it a free flap. It looks like you did a hinged flap here where you take it the edge of the hole and flap it over the hole itself. When you do a free flap, that's even tougher, but I think that's a great technique. And one of the pearls that I would offer is, I agree with you, Dr. Dhawan, that the hardest part is trying to keep it intact in one piece. This is one of the few times that I actually like to use either a Tano scraper or a flex loop, because I feel like it helps me outline the area and keeps it broader so that I can peel it all over in one collective sheet. But that was a really nice set of tips to offer. Thank you.
Dr. Christina, in fact, for the free flap, also I'm using the same technique, and you can use the free flap in the case of the failed macular hole surgery. The same, put the flap over the hole, close the infusion cannula, put the colored viscoelastic, and simultaneously on the air, and you can take out the whole viscoelastic at the end of the surgery and the flap will be there. So the headache on the table to lose the flap is almost minimal.
Wonderful. Thank you. I'll have to try that.
Thank you. Dr. Shukla, if I can get you in at this point, do you also use hinge flaps in your practice? Are there any specific indications where you do that?
Yeah, there are two things actually. First of all, Atul, excellent surgery. And actually, this is actually better than a flap because this is just a hinge actually, which is probably the simplest surgery you can do for a large macular hole. And it has been described as published in Retina. And we had a discussion with Dr. Lingam Gopal. He also used this technique. So the thing is, as I said, I have only reservation against stuffing something into the macular hole. This is perfectly acceptable. I personally use a flap, any kind of flap, only on very large macular holes. So I have actually, my papers are under submission. I have closed macular holes up to close to 1,000 microns, at least up to 800 microns, with regular ILM peeling, provided is extended more on the temporal side. So what Atul's technique also points is the temporal part of the horizontal raphe. If you look at the macular holes, they are horizontally oval. So it is the horizontal centrifugal traction which is most important. And this is what is addressed by this kind of technique.
So just one more thing, sir. Shukla, sir, you can tell us about the heavy BBG which you have introduced to us, heavy BBG. Because you talked about the osmolality, everything. So in case HPMC, it will be hyperosmolar.
That's heavy BBG actually is something that we published, and I think Naresh is going to publish again. So it is basically there's a much expensive option already available in the market with the PEG, polyethyl glycol. But we made BBG heavy simply by mixing it with the 5% dextrose normal saline. And that basically makes it sit down, so use less amount. And also it becomes more isoosmolar and more tolerable to the retina. So we use more diluted dye, and we also use better osmolarity. What was toxic about ICG, if you remember, I mean, a lot of people gave up ICG for the wrong reasons, was because of the low osmolarity, because of the use of distilled water. If you use DNS with the ICG, even that is not as much toxic. Thank you.
Dr. Vivek, can I come in? Saravanan sir?
Yeah, please, Dr. Joshi.
A very, very nice video, Dr. Atul. But just there's another technique also. What we can do is now we are doing this, the inverse flap technique under PFO. So under PFO, when we flap it, as Shukla sir said, we don't have to stuff it inside. Once you make the flap, because of the sheer density or the molecular weight of the PFO, the flap stays on the macular hole. The challenge is how to remove it. When we tilt the eye nasally, the PFO moves in the opposite direction, opposite to the flap. And then we start the fluid air exchange and we drain it. I don't see any of the flap getting dislodged. So with this technique also, we can do it instead of viscoelastic. Just another suggestion.
Dr. Joshi, at this time, if you see the video, this technique is the easiest technique. Just make a temporal ILM flap, big flap, put it over the hole. Don't press this, nothing, because this ILM flap will cause.
I'm not contemplating
one second.
I'm just
Joshi, one second. Just put it over the hole. This flap will act as a scaffold. Now put the colored viscoelastic on the temporal side and tilt the eye towards the disc. The flattening of this causes the ironing of the flap at the end of the fluid air exchange. So there is nothing that which PFO will do and this colored viscoelastic will not do. And
Correct.
this colored
The only thing I was worried is when you mix BBG with the viscoelastic, and in case there is no 100% removal of the viscoelastic, then the BBG itself might be a toxicity. That was my only concern, but it's a good alternative technique.
No,
right. So I think in the interest of time, we will close now because we have exhausted our time slot. Many thanks once again.
Thank you all. I thank AIS Dr. Partha Biswas for giving us the opportunity. We had wonderful speakers today and also all the panelists. And thank you to Vivek and Saravanan for the great moderation. Thank you all. See you later. Bye.